So I will not be looking at the doubts while we go through the content, and I will be definitely giving you all um, in the end once I complete the lecture time to ask your questions. So please hold on to your questions while we are discussing it and try to grab and learn and receive the concepts as many as you can. So it's a very important topic, very, very important topic, local anesthesia in dentistry. And about oral surgery questions are loaded with the questions on local anesthesia. So for every extraction questions, every third molar extraction questions, you would find the LA question intertwined for infiltrations, for the blocks, what material you will choose. They will give you a situation or a medical history where adrenaline is contraindicated. There is a history, cardiovascular disease history, and there might be allergy with adrenaline. So what causes that? And then what is the local anesthesia of choice in pregnant patients? Local complications of local anesthesia, systemic side effects, systemic effects. Suppose after giving local anesthesia, your patient starts showing certain signs. What does that mean? How in emergency you're going to manage it? What does that mean? What kind of local anesthesia gives what kind of systemic signs? So talking about all the information about local anesthesia, we are covering the entire local anesthesia chapter from TG today. And we'll also do anxiety management, half of it today, right? As the time is constrained, so I will be covering local anesthesia entirely today and almost half of the anxiety management as well. So let's start, and every question, possibly every topic that I'm going to teach you will be related to the examination questions. I'll give you the examples as well. So basically, there are two forms of anesthesia that you would be administering in your dental treatments. One is the infiltration technique, or other is the block technique. Infiltration is a general term used here where you're locally injecting the anesthesia at the site. It, of course, includes intraosseous infiltration and intraligamentary techniques because they are injected locally to where analgesia is required, around the tooth. Whereas the regional block is actually given adjacent to the nerve, where the nerve is present, and it provides proximal to the site where analgesia is required. And of course, wherever the entire nerve distribution goes, the anesthesia is achieved on all those teeth. For example, if you want to work on the mandibular molars, you would require inferior alveolar nerve block, right? Sometimes in dentistry, you will also be using the local anesthesia on the topical applicant, right? Sometimes for minor procedures like band removal and crown placement. Other than that, sometimes in scaling and root planing also, you can use the local anesthesia applied topically. Those questions are also coming up in the exam now. The topical use of local anesthesia for your scaling and root planing, especially when the patients complained of sensitivity while scaling. Instead of injecting the local anesthesia and infiltrating, topical application is also recommended for periodontal use. Some patients who are needle phobic and you require a block in them, sometimes there also the topical application will help eliminate the needle prick pain, right? Upon definitely upon injection, there is going to be the deeper tissues are still not anesthetized, so there will be discomfort. But at least the needle prick can be handled in the needle phobic patients by eliminating the mucosal surface pain. So depending upon the type of anesthesia that you're giving, whether it's your infiltration or your block injection or your topical application, the time duration, the time that it takes for the onset of analgesia is different for all the three types. And you must remember these because this can be an actual examination question. Infiltration technique will take 2 to 3 minutes upon administration. Then your topical will take 3 minutes and the block will take 4 to 5 minutes. This should be the waiting period on which the onset will begin. The duration, how long the anesthesia is going to last, will depend upon what LA agent you have used, what is the dose that was administered, and what was the method of administration, right? Now, some of the medical practitioners also have some experience for administering local anesthesia via their infiltrations or block techniques. They may use it. Sometimes a patient can present to the medical practitioner for severe acute dental pain, and sometimes medical practitioners may also use it. Whenever you're choosing a local anesthesia agent for your patients, which you will be doing a lot in the examination for a lot of questions, you should always consider the benefit and the harm of the drug. So I'm going to be talking about the clinical situations, for example, where the articaine can be chosen, where adrenaline should be avoided, and when adrenaline avoided, what should be the agent of choice, what should be the best sequence for, or the gold standard whenever the adrenaline is contraindicated, which should be your first go-to local anesthesia. And if that is not given in the exam as an option, then what should be your second go-to anesthesia? So I'm going to be talking about all those clinical concepts which are coming in the examination every single time. Not a fail. Local anesthesia is hottest topic there is. Just to add, TG only covers the local anesthesia pharmaceutical aspect, but doesn't cover the technique aspect. So in our hot notes, we also have the local anesthesia technique hot notes, where we have given entire Malamud screenshots, entire Malamud references, but in a concise, shortest manner. So you can prepare all the LA techniques, because other than the agents, the LA techniques are also getting asked. So this chapter needs to prepare. If you take LA in ADC, let's talk about LA in ADC. It would require you to do the TG chapter, this one, and also the hot notes of LA techniques. If you combine these two resources, it is entirely sorted, right? Your entire local anesthesia syllabus for ADC is sorted just by doing the LA technique hot note and this chapter from TG. This will give you the selection of the agent. Then the dosage is also asked. How many mLs can you give? How many cartridges can you give? And I know the math can get really irritating, and that's why I've given you all a magic number. I will also talk about that magic number as we move forward and how to calculate it. Okay. So now your vasoconstrictors in LA, we know most commonly the vasoconstrictor that you use in your LAs is adrenaline. The use or addition of vasoconstrictor to your local anesthesia is for the reason that it prolongs the LA effects. It prolongs the depth and duration of the anesthesia because it reduces the rate of local anesthesia circulation and absorption into the circulation. So it definitely increases the depth as well as the duration of the anesthesia. Most commonly used is adrenaline, but adrenaline has a very highly oxidative tendency. Because of its highly oxidative tendencies, to prevent that oxidation, an antioxidant is added. An antioxidant or a preservative like metabisulfite. Now, metabisulfite is a notorious agent. It can cause allergic reaction in certain patients who have allergies to sulfites. So a lot of patients can come, and a lot of cases in the exam can come and tell you that they have adrenaline sensitivity. They have adrenaline allergies. So must know that it is not a true allergy to adrenaline or not a true allergy to lignocaine. That's extremely rare. The allergy is coming from the fact that metabisulfites, which are added to the adrenaline containing local anesthesias, they can trigger allergic reactions. So the true allergy is coming from the metabisulfite, not from adrenaline, not for local anesthesia. Right now, this is another important point and a very, very important examination concept. Any examination history and SBQ, if you've got a history that your patient had myocardial infarction in the previous 6 months, or any unstable angina, uncontrolled hypertension, and uncontrolled arrhythmias, or uncontrolled hyperthyroidism, you would avoid adrenaline containing solutions. And instead, you would use fellopressin containing agents. So wherever your adrenaline is contraindicated, be it your allergies to metabisulfite or your cardiac conditions like myocardial infarct in the last 6 months, unstable angina, uncontrolled hypertension, uncontrolled arrhythmias, and uncontrolled hyperthyroidism, they all will require avoidance of adrenaline containing LAs. And instead, what you would do, you would give the local anesthesia solutions which are containing phelipressin, right? So phelipressin doesn't have highly oxidative tendency. That is why it does not require metabisulfite as a preservative. And also its vasoconstrictive action is quite minimal on the myocardium, on the heart muscles. And the quantity is also extremely low. So it is also safe for use in pregnancy, as well as in the cardiac patients, as well as in the metabisulfite allergies. So this concept is absolutely clear, I hope, that the first line of treatment in the patients where you cannot give adrenaline is phelipressin. Now you will see questions in examination where the phelipressin, prilo with phelipressin option is not given. So either the option would be lignocaine plain or lignocaine with epinephrine, articaine plain or articaine with epinephrine, or then mepivacaine. Then you must know that mepivacaine has its inherent vasoconstrictive property. Mepivacaine is the only local anesthesia which has its own vasoconstrictive action. So when phelipressin is not given, your second best choice in such situations should be mepi plain 3%. Okay? Now let's talk about the adverse effects. We're going to be talking about the general considerations about them, the local complications and the systemic complications. These are the two kinds of complications that you would expect when you are dealing with the local anesthesia. And adverse effects are associated with possibly every drug that you read about in TG, whether it's NSAID, paracetamol, your antibiotics, your chlorhexidine, harmless to harmless drugs, and even more scheduled categories drugs. All kinds of drugs come with adverse effects. And TG emphasizes on every chapter the considerations regarding the adverse effects of those drugs. For local anesthesia, you would have local complications, systemic toxicity, and allergic reactions. So for any clinician who's using local anesthesia, because allergies are possible, severe systemic toxicity is possible. That is why they must have life-saving drugs and equipment available. So resuscitation drugs, which is your adrenaline, right? Then equipment, oxygen, and you should have the capacity and the knowledge to manage the immediate symptoms of systemic toxicity. So first of all, in any case, when you're suspecting that after administering local anesthesia, the patient is starting to give the adverse effects, some kind of delirium, some kind of CNS effects, CNS toxicity is the first sign. Whenever the systemic signs are observed, CNS signs and symptoms show up the first. Only exception to that is bupivacaine. In bupivacaine, your cardiotoxicity signs come up first. And cardiotoxicity, in fact, is more serious than your CNS toxicity effects. Because CNS ones initially, even in the lower dose, you can observe and then you can control and stop the administration. But cardiotoxic effects can be immediately life-threatening. And that is why bupivacaine is a long-lasting anesthesia. It gives you the cardiotoxic effects first, and cardiotoxic effects, whenever seen, they are far more serious indicator of a toxicity than your CNS signs. Okay, I hope I'm making all this sense till now. These are all exam questions. Which symptoms will come first? Cardiotoxic. So suppose arrhythmia is given and delirium is given. You should know that with anesthesia, you would get delirium first, right? And not the arrhythmias or not the palpitations or not the cardiac signs first. But in bupivacaine, opposite. Your cardiac signs will come first. Okay? Now, your usual problems that arise with your local anesthesia, they come from the injection technique. Either your technique was incorrect or you injected on the incorrect site farther away from the nerve. That will lead to improper achievement of the anesthesia. It can lead to either complete failure or partial failure. So whenever this happens, instead of dosing again and again, you should first review your technique and the patient's anatomy, right? Because sometimes in the mandibular nerve, there can be an anatomical aberration. So observe that as well. You can give a repeat injection after your first failed technique, but do not exceed the maximum dose. And do not even try to achieve the maximum dose, because even a single rightly placed cartridge is enough to achieve the anesthesia required for the dental purposes. Another effect that you can have is that you can traumatize the nerves and surrounding tissues. And the systemic effects, if you inject it directly into the blood vessel, it goes into the circulation, gets absorbed by your organ systems. That's when your systemic signs show up. If it reaches brain, and it does reach brain first, so CNS signs come first, and then cardiotoxic. Okay, so to avoid these systemic effects, always do the aspiration. Inject slowly and continue to monitor your patient's response to the anesthesia, that these symptoms are not occurring. Okay. What are the local complications now? This is exactly what you will find in the examination. With the local complications that can arise with your local anesthesia, it's mostly depend upon the some kind of nerve injury or prolonged paresthesia, dysesthesia, even temporary facial nerve paralysis. Recently in the exam, you have gotten a question. I recently did it in the UF2 class as well, if you remember. After anesthesia, patient wasn't able to blink their eyelids. How will you manage that patient? That we will also cover in the TG lectures when we talk about the emergencies, the ocular emergencies, the temporary facial paralysis because of the periocular muscle paralysis, because of the anesthesia of the facial nerve. Again, it is a technique error, or sometimes anatomical aberration as well. Sometimes the facial nerve innervation and branches can be present around that area. So not always your technique error, sometimes anatomical variation. Both are the likely causes. But unless you know to read the signs, you would not be able to identify that it is a temporary facial nerve paralysis because of the facial nerve anesthesia. The management also you must know and learn, which we will cover when we go to that class and chapter. Okay. So permanent anesthesia with your local anesthesia or minor injuries is very rare. Usually the neurological complications will come either you have directly traumatized the nerve, or sometimes under the nerve sheath there has been a bleeding, or sometimes localized neurotoxicity, right? These are the possible reasons. So now when you compare your anesthesia techniques and the agents that are used. Earlier, it was believed that Artican leads to more prolonged anesthesia, which it still does, but also permanent paresthesia nerve risk was higher. Now, those studies, the recent studies, have not supported this finding anymore. I know it may come across as something that you have to unlearn from maybe last 10 years, right? But this is the new concept now, that Artican leading to permanent paresthesia, the recent studies are not supporting it anymore. So this is out of that's an obsolete concept now. And even in the TG3, it was given that Artican should only be used for infiltration, never for blocks. That has also gone obsolete now. TG4 has recommended that you can use Artican for blocks. And in fact, it has given you under the sublinks a reference where they have compared the lignocaine anesthesia versus Artican, saying that Artican anesthesia is superior, which anyways we knew because it gives you a deeper and prolonged anesthesia always. It was never the first choice, always because of the risk of the paresthesia, not for any other reason. But that reason has been completely eliminated now. So you can completely safely choose now Artican 4% with adrenaline as your local anesthesia of choice when asked in the exam, even above your lignocaine with adrenaline. Right? So that's going to change and update a lot of answers in our question bank, which we are on to. So now, if there are certain signs, neurological symptoms which are seen and observed after giving an Articaine anesthesia, usually reassurance and observation is required and they are self-resolving. If within 3 months they have not resolved, then you can refer to an oral and maxillofacial surgeon for further analysis. Another local complication that can arise is trauma to the tissues, which can occur because you can accidentally injure the muscle, and it can also cause some trismus, right? Either as a direct effect or due to puncturing the muscle and inducing bleeding due to the injury to the muscle. If you find trismus after giving anesthesia, you will seek specialist advice and refer the patient to the oral medicine or oral surgery specialist. But early management is required, referral is required. This is not wait and watch situation. This is a specialist situation because it is because of the internal bleeding and trauma to the muscle, right? Sometimes far more serious complications can also arise, like a cartridge explosion or needle breakage within the tissues. They also would require immediate specialist referral. Now, the systemic toxicity signs: when the anesthesia is accidentally injected into a blood vessel, an intravascular injection. So definitely within the circulation, immediately there is an excessive dose. And sometimes because of overdose also you can do this. Or sometimes because the body's organ system or drug clearance system is impaired, right? With maybe kidney disease or liver diseases. And sometimes in children where you have exceeded the maximum doses. So these kind of systemic toxicity symptoms, they are more likely when you have given higher plasma concentrations. That is why never exceed the maximum recommended dose, and it's crucial that you know the formulas, know the magic numbers. Especially for lignocaine, it is asked in the examination. So I'm giving you 3 magic numbers today for the lignocaine calculation. I will also show you how I calculate the magic numbers, so that in future, if you have more about, okay, tell me what's the magic number for Articaine in mLs, what's the magic number for Articaine in cartridges, what is the magic number if the cartridge is 2.2, what is the magic number if cartridge is 1.8, and then what is the magic number if the cartridge is 1.7. I can only give you 3, which is most commonly asked for lignocaine, but I'll show you the technique how to calculate. So if you are curious and want to learn as many as you can, simply calculate, use your calculators, and you can arrive at it. So basically, most importantly, systemically, you will see the signs which are neurological, psychiatric, cardiovascular, and then respiratory. Sometimes methemoglobinemia is also seen. So methemoglobinemia is a rare side effect, but seen definitely, and also at a very higher dose. Minor CNS effects, which is restlessness, anxiety, tinnitus, dizziness, blurred vision, CNS depression and tremors and drowsiness. They indicate early systemic toxicity. These are still the milder effects. And then it should immediately alert you to stop administering the anesthesia, right? And later, you will find that there are systemic effects which are cardiovascular, which are more serious. So to prevent them to occur, you should immediately stop administering the anesthesia as soon as the CNS effects come. Okay, particularly your bupivacaine, as I told you prior, also gives you the cardiovascular signs before your CNS effects, right? As soon as you see the first and the mildest of the systemic signs, which is your CNS effects, you will stop administering LA and provide appropriate management. Now, the third complication that can come from your LAs is the allergic reactions. True LA allergy is very rare, but the common allergy comes from the metabisulfite, which is used as a preservative for adrenaline containing solutions. Okay, so take a proper history, and if the patient reports of any such allergies in the past, you would use felipressin or avoid a vasoconstrictor. So that means when Feli is not given, you can choose mepivocan 3% or even plain articaine. Now, methemoglobinemia. It is another side effect. It is actually a life-threatening condition. It is rare, but if happens, it is life-threatening. Okay, so what happens in methemoglobinemia is that your methemoglobin is only minor percent of normal hemoglobin in the blood. But when methemoglobinemia happens, there is an increased amount of methemoglobin in your blood circulation, and methemoglobin lacks the capacity to transport oxygen to body tissue. So methemoglobin doesn't bind to oxygen, whereas your natural other hemoglobin, it binds to oxygen, carries it to the tissues. Whereas in your methemoglobin, it doesn't have the capacity to bind to oxygen. So it depletes the vital organs of the oxygen. And that is why you'll first see like a gray bluish skin, lips and nail beds all going without oxygen, turning blue. This can be your first sign. And then when your brain starts receiving less oxygen, so headache, shortness of breath, fatigue, drowsiness, confusion, and tachycardia. So it can happen after certain local anesthesia, but in the higher doses. Most importantly, it has been noted with prilocaine, but at doses which are greater than 600 mg. Clinically, they are not done unless inadvertently you have exceeded the maximum dose. Other anesthetic agents which can lead to same methemoglobinemia is benzocaine, lidocaine, articaine, and tetracaine. It happens only at an unregulated high concentration dose, so you don't have to worry about it always. But certain individuals can give you a G6PD enzyme deficiency. What happens is, especially in the African and Asian population, this enzyme deficiency is found. So even at your therapeutic doses of LA, not just prilocaine, in fact, any LA, it would lead to methemoglobinemia. That is why anyone who suggests that they have a G6PD deficiency, you should not administer LA altogether and first talk to their medical practitioner and their condition, whoever is managing that condition, that what drugs to be avoided, what the patient can take safely, and how much dose. Only then you administer them. So G6PD deficiency is usually remains hidden also in certain people. It can become symptomatic or present itself by certain infections, certain foods, or certain drugs can trigger the episodes of jaundice or anemia, and that's how they get diagnosed with G6PD deficiency, and most prevalent in populations of Africa and Asia. Now, choosing the local anesthesia, most important. I think by now everybody has gotten the idea that your lidocaine is a short-acting alone plain. Mepivocaine alone is also short-acting, not to be given in children 3 years younger to 3 years. Prilocaine alone is also shorter acting. With adrenaline, they all become intermediate. Articaine, lidocaine, mepi, and prilo, along with epinephrine, from the short term, they become to the intermediate acting. So again, articaine can be used now for the blocks or infiltration. There is no restriction. In fact, can choose it over lignocaine also in situations because it gives you the deeper, longer, better anesthesia. But contraindication is 4 years or below, you cannot give. So commonly used for routine dental procedures is articaine and lignocaine. Mepi and Trilo are not commonly used. These two are the commonly used. So if one of the options is given in exam and they ask you what will you choose, you can choose any of these. But if both of them are given, you can choose articaine with adrenaline safely now. There is no risk of permanent nerve anesthesia. I hope that concept is clear with everyone. Prilocaine with Feli is used when you cannot give adrenaline, when there is a contraindication, like with the metabisulfite allergies or with a recent myocardial infarction, unstable angina, uncontrolled hypertension, uncontrolled hyperthyroidism. Bupivacaine and ropivacaine, they are your longer acting anesthesias. Bupivacaine is not given in children below 12, whereas ropivacaine can. Bupivacaine also is more cardiotoxic than ropivacaine, and the cardiac toxicity symptoms, they manifest before neurological toxicity, as I taught you prior as well, right? So bupivacaine with adrenaline also more cardiotoxic than ropi, and the cardiac signs come before neurological signs. For every other anesthesia, cardiac toxicity comes after your neurological toxicity. Okay? So when above the 4 years of the age, Articaine should be chosen if both the options are given. I hope I'm making myself crystal clear here. Absolutely. So what should be the doses of LA that's given? This you need to memorize for every local anesthesia. Milligrams per kg differ. And you have to memorize their maximum safe single doses. How many cartridges can you give? How many mLs can you give? This gets asked in the exam. So I've written down the magic numbers here and I've seen the request on the chat. Let me show you the calculation of the regular formula. Okay. Basically, for any calculation, this is how I did for the magic formula of ML. So let me show you just one and then rest you can all calculate. So for a 70 kg man, for example, so actually this magic formula came because of a reason that I was finding when I was doing the exam myself and preparing the the exam myself. I found it really difficult that I thought that in the examination, if something comes, I don't want to do and spend 5 minutes on this question just doing the math. And I hate math. So sometimes it's good to not like doing something, because when you don't like doing something, you improvise and you find ways to find shortcuts, right? And find a way around it. So I think it's also important to focus on your dislikes, not just your likes, right? So math is, I dislike it wholeheartedly, and I thought it's too much math, and let's find a shortcut. And let's find one number I can divide or multiply my weight with, and I can get away with it, because basic division and multiplication I can still handle. I think all the pretty girls hate math. That goes, I think, in the world for that, right? That I think goes, somehow it doesn't work. So let's do this. I think there has to be a science behind it, right? Your looks and math, they don't go along. So 70 kg man in the lignocaine, 7 milligram per kg is allowed. So you first multiply by total how many mgs you can give. So that becomes total of 490, right? If I'm doing the multiplication, right? And then you divide it by the 20%, because you have to calculate, because 2% of lignocaine is 20 milligram per ml. So you divide it by 20. And then this is your total ml that you can give. So this, my friend, is the math for total mLs, where you multiply by the weight, the total allowed maximum dose per kg, and then divided by the percentage. So for lignocaine, it would be divided by 20. For mepi, it would be divided by 30. For articaine, it would be divided by 40. 3%, 2%, 4%, like that, right? So far, this much is clear. This is the basic. If anything comes, suppose for mepi comes, for articaine comes, for lignocaine comes, always remember their percentage of the solution, which is for lignocaine is 2%, mepi has 2 and 3, prilo has 3 and 4, RT is 4, right? So division factors would be 20 for lidocaine, mepi also 20, 30 if it's a 3%, and exam will give you, whether it's a 4% or 3% or a 2% solution. So the division factor is simple. If it's 4, it's 40. If it's 2, it's 20, right? Or 330. And multiply by the maximum dose. So this is the remembrance part. For lidocaine 2%, 7 mg per kg is allowed. Then maximum dose for your MEPI, prilocaine 3% is 9 milligram. For MEPI, it's very variant and it's not specified. Prilo 4% is 6 milligram per kg. Articaine is important, I would say, because now it is becoming a popular agent. With lignocaine, know the RT formula. So RT 4% you will divide by 40, but you will multiply the weight by 7. So it's same as the lignocaine, 7 milligram per kg, but the division factor will be 40 rather than 20 because it's a 4% solution, not a 2% solution. I hope math is mathing a little bit. See, this is why we have magic numbers. So let's go back to our calculator. So this is your mLs. 70 kg man times 7 milligram per kg divided by 20, which is the 2% solution. That's your 24.5. Yes, I expect you to be, Priyanka, confused. That's fine. So this is your mLs. Now further to get the cartridges, for example, you are using a 2.2 ml cartridge, you will further divide it by 2.2. So much math. And it's 11.13, which will be rounded off to the lower number, which will become 11 cartridges. Now that can be done simply by using a magic number for lignocaine. So for weight is provided to you. So for mLs, you will divide by 2.8. Now don't ask me how I did it. It's done through the calculator and it works. So ml will come 25, right? And then for a 70 kg man, divide for the cartridges by 6.3. Comes 11. Works like magic. Okay, that's why the magic number. And I also calculated one more magic number for 1.8 ml cartridge because a lot of you asked. So 70 kg man for 1.8 ml cartridge, 5.1 is the magic number. So 13. Okay, that's it. And that's how we make math. Then comes your all the formulas and calculations and weight amount per kg that you must memorize. And this is the LA chapter. And that's how, yes, Articaine 1, we will talk about Sakshi in the next class. And we'll discuss the magic numbers for Articaine in the next class. How about that? Okay? That is tomorrow. Not tomorrow. We're having our next TG class on Thursday now. Yes, secret. All right. So let's start anxiety management. Before that, let me give you a quick review of the LA chapter. That's what we do after every chapter that we finish. Let's have a quick review, everyone. Okay. So local anesthesia, a lot of questions coming up. You use it for infiltration technique and your regional blocks technique, right? You can use it for topical application. The time of onset varies. Infiltration takes 2 to 3 minutes. Topical application takes 3 minutes. And block takes 4 to 5 minutes. So local anesthesia contains adrenaline and vasoconstrictors because it prolongs the depth and the duration of the anesthesia, reduces its systemic uptake and into the circulation. So prolongs the effect of local anesthesia locally. Some patients may have allergies to adrenaline. In those cases, you will choose fellopressin. The allergies is coming from the metabisulfite and not from the adrenaline. Adrenaline is also contraindicated in the myocardial infarct, which is only recently in 6 months, or uncontrolled hypertension, uncontrolled arrhythmias, uncontrolled hyperthyroidism, and unstable angina. Fellopressin is the drug of choice. So Prilo and Feli you would be using as your first line of treatment when adrenaline is contraindicated. Adverse effects are 3 types: your local, your systemic, and your allergies. The local effects are because of your failure of technique or anatomy aberrations which you didn't record for, trauma to the nerves or muscles, and systemic effects if it gets uptaken into the systemic circulation, either overdose or because of injecting intravascularly. So to prevent your systemic effects, always aspirate. So local complications are nerve paresthesia, dysesthesia, temporary facial nerve paralysis, prolonged anesthesia. Earlier, Articaine was believed can lead to this, but now no more considered, no more support and evidence. So Articaine has become your LA of choice for blocks and infiltrations. Better anesthesia tops up lignocaine now. Trauma to the tissues directly can also lead to local injuries. Hematoma can happen, trismus can happen. Immediately do the specialist referral. Serious problems like cartridge explosion or needle breakage also rarely can happen, but still immediate management with specialists. Systemic toxicities because of the higher plasma concentration, so higher doses, or because of the intravascular injection, or because the patient's drug clearance was challenged, or rapid systemic absorption. Signs of CNS come first, then comes the cardiotoxicity. In bupivacaine, opposite, cardio comes first, neuro comes later. So the milder signs of CNS toxicity should be addressed immediately, like dizziness, tinnitus, blurred vision, tremors, drowsiness, and immediately stop giving anesthesia, make the patient recover, manage emergency management based on the ABC, airway, breath, circulation signs. Allergies come from metabisulfites, not true to any anesthesia, very rarely to any particular LA agent. Only from metabisulfites is very commonly seen, so do not give. Methemoglobinemia is another which is mostly associated with the higher dose, but also seen with G6PD deficient patients. So take history correctly. Otherwise, if it's not a G6PD deficient patient, then it's very rare and will happen at a 600 mg dose of prilocaine, which is with inadvertent extremely high dose given. Signs and symptoms are bluish skin, lips, nail beds, shortness of breath, headache, fatigue, drowsiness, confusion, and tachycardia can be life-threatening. All the agents can give, mostly seen with prilocaine, but at a higher dose. Choosing the anesthesia, I've told you, Articaine is first choice, lignocaine then, with adrenaline, both of them. And wherever the adrenaline is not, then Prilo with Feli. Articaine cannot be given below the age of 4. That also you need to memorize and take care if the children or if the pediatric patients are asked in the exam. You should not choose. For pregnant, all these are safe, Nivedita. Even Prilo with Feli is safe. Adrenaline is safe. All are safe. Unless the pregnant patient also has an allergy to metabisulfite, in that case, you will not choose adrenaline. But that's not coming from the pregnancy, that's coming from the metabisulfite allergy. Yes, all safe. There is no challenge. Then I gave you the magic numbers and calculation method. Preeclampsia shouldn't be given the adrenaline, Nitya. That's hypertension. Preeclampsia by definition is hypertension and sometimes uncontrolled also. So avoid that. Memorize the doses. Lignocaine is 7 milligram per kg. Mepi is not given. Prilocaine is your 6 milligram per kg. Articaine is also 7 milligram per kg. I'm actually anticipating adrenaline, Articaine calculations may come. So in the next class, we will learn the magic formulas and we'll calculate it in the next TG class. Without adrenaline push for definite. So Prilo with Feli. No, MAO inhibitors is no more a challenge. So that is an obsolete concept again. Steroid patient also no challenge with the local anesthesia. Long-term steroid has 2 challenges, adrenal crisis and the risk of NSAID toxicity if it's a systemic steroid. And also there's an increased bleeding risk. Steroid is also in the bleeding risk factor chapter. We'll come to that also. Yes. So 3 risk with steroids. Long-term steroid, topical, inhaled, systemic gives you adrenal crisis. Long-term systemic gives you NSAID toxicity risk. And then comes your bleeding risk, increased bleeding risk with prolonged corticosteroids, right? All right, so good review, everything understood, recapitulation is great. Let's do anxiety management. I will not be doing it fully, the first 4 pages till page number 70, and the next we'll resume from the next class. So anxiety management in dentistry, I've actually given you an entire class on this when the new TG4 was not announced for the exam. If you remember, we did an entire new separate class on the anxiety management because I was already doing new TG chapters with you since the beginning. So you've already done this, but I'll still go through it as we are doing it for the first time because many of you may be doing it for the first time. So anxiety management emphasis should be given to all the non-pharmacological strategies like distraction, suggestion, or relaxation techniques, right? And then the pharmacological management should be considered when these non-pharmacological strategies do not work. So there are different levels of sedation which are achieved: minimal, moderate to deep. In dentistry, there's only room for minimal. Moderate only for the dentists who have the license with the dental board and are trained for that. But still, regular dentistry, minimal sedation only works. Deep sedation is again with the hospital and not for the dental use. This is done by anesthetists and medical practitioners. So minimal sedation is also known as anxiolysis, where you reduce the anxiety, but the patient remains conscious and responds to the commands and even light tactile stimulation. They are fully in their consciousness. They are responding to your verbal commands and tactile stimulation as well. Only their anxiety is diminished. It can be achieved by oral BDCs or inhaled agents like nitrous or methoxyflurane. In dentistry, methoxy doesn't have much role, so nitrous and BDCs. Sometimes cognitive function or coordination can be impaired during the minimal sedation, but no interventions are required to maintain a patent airway or a ventilation or cardiovascular function. Whereas they both may be required and absolutely required in moderate to deep sedation methods. Moderate and deep sedations are achieved with IV drugs, right? And this depress consciousness. In moderate, consciousness goes down but they retain the ability to respond to verbal and tactile, but the consciousness doesn't remain. Whereas in deep, they don't respond to any kind of verbal commands, only to painful stimulation, noxious stimulation, not for dental use. They require maintenance of airway support. Inadequate ventilation or impaired cardiovascular function can also happen. That's why you will need to provide support. Deep sedation is, yes, a kind of a general anesthesia, depending upon if you're doing it, like how deeply you can do. Even GAs have different depths. So dentists are restricted to providing minimal sedation unless they are endorsed by the dental board to provide moderate sedation. Deep is not done by dentists or in dentistry. So first emphasis is on the non-pharmacological strategies, which include like modifying the environment, calming communication techniques, and special considerations for anxiety management for children in dentistry are also advised for special care that you can take care of your pediatric patients. Deep breathing techniques, muscle relaxation, guided imagery to manage anxiety. So the environment modification includes using soft calming colors, soothing background music, a weighted blanket to provide a sense of security, aromatherapy to mask the clinical smells. Then distraction can be achieved by television, headphones with music, or virtual reality glasses. Your communication strategies should also be in place to handle and reduce the anxiety by using non-verbal cues, having positive contact, positive communication, maintaining eye contact, showing interest and understanding. Do not interrupt, do not rush the patient. Express empathy and reassurance. Validate the patient's feeling without belittling their fears. And then give them clear instructions in non-technical language. Do not use the dental jargons. Allow them to ask you questions and provide them clear and concise answers. Do not use any threatening language for your patients. So now for the minimal sedation, there are certain safety considerations, adverse effects as we discussed for every category of drug. Again, so there can be a risk of oversedation, drug interactions, airway obstruction, respiratory depression, cardiovascular depression with all these methods, both oral BDCs as well as nitrous, if not monitored well and if not done correctly. That is why the dentist, whoever is planning to do it, they should be competent in both basic life support and first aid. They should have the sufficient knowledge and training and continue to do their CPD programs on the same techniques. You should provide first do the thorough assessment of the patient for case selection and then choose the correct method, whether nitrous or BDCs. Obtain the consent from the patient or their substitute decision maker, whoever is responsible. Then provide written instructions to the patient and their carers before the procedure. It should be obtained a day before the procedure. Then you prepare for the procedure and post-op care. And after you have administered the agent, you will monitor the patient until the full effects of the sedations are recovered. This is your monitoring. These are the things that you must take care of to prevent any adverse effects or adverse outcomes. How will you do the patient assessment? So not all the cases will be suitable for oral BDCs and not all will be suitable for inhaled agents. The safest still being the inhaled agents, then the oral BDCs. Why? Because you can titrate and control the depth of anesthesia or depth of sedation more with the inhaled agents rather than with the BDCs. The patient selection will happen by assessing certain suitability factors, like there should not be any heart disease, cerebrovascular disease, lung, liver, or kidney disease, any allergies to any of these agents, any severe anxiety which has not been previously managed with adequate doses of minimal sedation. Those are the factors that you must be assessing the patient for before you select the agent. If you have any of such histories present, either do not administer, refer to the specialist, or talk to the medical practitioner for these agents. Yes, this is all for general dentistry, right? I don't know what the buzz mean. I hope you're asking about the oral buzz or oral B disease. Now, what are the choice of drugs? So two kinds are used, oral BDCs and inhaled. Both are suited for your general dental practices. Okay? But you must be doing CPD courses. You must be trained in both of them. It's not that you can't do, but you must have training in that and you must continue to take training and be updated with that. So the choice between these two becomes on the patient factors. What are the contraindications? What are the drug interactions? And what is the preference? There are certain contraindications to both, and we'll talk about them. But you will only choose one agent. You can't go BDCs as well as your nitrous both. No, always one agent, never a combination. Always a single drug. So what are the advantages of nitrous? It has rapid onset and offset. Quickly sets in and quickly also leaves the body. Easy to administer, can be titrated also. You think deeper level have been achieved, you titrate on a lower dose. You think it's still lighter, you can deepen the dose. Gag reflex is really well managed with nitrous. Disadvantage is that equipment, you have to have your practice set up with it. Not all the general dental clinics have nitrous, but if you do, it comes in really handy with your pediatric cases management and even in adult patients who have mild to moderate, moderate to moderate anxiety. Not mild. Mild would be first handled with your behavioral techniques. And then also you would require the patient's cooperation to wear the mask. So that also becomes one of the disadvantages. Contraindication through and through is if they have severe cold, they can't breathe through the nose, you can't use it. Any air trapped in the body, pneumothorax, bowel obstruction, recent middle ear surgery, recent eye surgery, or current bleomycin therapy, they are all contraindicated. What happens with the bleomycin therapy? Now, bleomycin therapy is used for cancer treatments, chemotherapy. And patients, if you use nitrous in them, it can lead to severe lung toxicity because of the fibrosis. Okay, so that's why with bleomycin also absolute contraindication. An ongoing bleomycin therapy, not a history of it. Then what are the BDZ's advantage, disadvantage and contrast? So advantage is it is well accepted, orally taken, easy to administer. You can also give it like you'll give it before the treatment. So anesthesia, anxiolysis and mild sedation starts before the procedure. Disadvantage is slower onset and effect remains after the procedure also. So requires supervision after procedure. And the wide variety of responses can come from the patient. Dose cannot be titrated once you have administered it. And the adverse effects are lot many, whereas with your nitrous, there were none. Not like it kind of very safe administering drug. That's why nitrous is preferred when both are given. Unless, yes, there were an absolute contraindication like air cavities or bleomycin going on and nose blocked or cannot wear the mask, claustrophobic or something. Then in BDZs, you get memory declining, ataxia, delirium, dryness of mouth, blurry vision, then low blood pressure, slow breathing, and paradoxical reactions in children. These are quite wide variety of adverse effects that you would find in BDZs. And the prolonged action, prolonged effect after the procedure makes it risky and a prolonged supervision is required. Contraindications of B diseases cannot be given in pediatric patients simply only from adolescents. 13 and below, don't give. Older patients, don't give. Cognitive disability, don't give. Using any other sedative agent, do not give. Obese, obstructive sleep apnea, do not give. Lack of social support, somebody caretaker at home, do not give. So school, any sedative substances, any cognitive disabilities, obesity, OSA, older age, and lack of social support, and not in children below 30. So those are your contraindications of BDCs. So use of oral BDCs for minimal sedation in patients who are using any other sedatives, you would be contraindicated in that and you would choose nitrous there. Then in children below 13 also nitrous you will choose. Rebound anxiety is an effect which can come from BDCs, but they are not seen with the drugs which are recommended in TG. So not associated with the drugs that you would use for dental purposes. Tolerance and dependence can happen. Nitrous side effects are or drawbacks are there are pressure changes in the closed spaces and cannot be given in the ongoing chemotherapy with bleomycin, risk of lung toxicity which can lead to because of lung fibrosis. Older and frail patients, cognitive disability, psychomotor impairment, they are all contraindications to benzodiazepines, right? Falls can happen, confusion can happen, memory dysfunction, amnesia, both retrograde and anterograde can happen, delirium, and they have a longer duration of action, so much more longer supervision. So do not give. Choose again there also nitrous. Minimal sedation should not be given in the younger children below 13 by BDZs, only with nitrous. Now, in your residential care patients, in residential care patients also, BDZs and nitrous are kind of restricted But for the dental treatments, you can still give them safely. Then your most important task will be to obtain consent for the minimal sedation. All the benefits, side effects, adverse effects should be discussed with the patient, their family, or substitute decision maker if involved. And they must consent before the day of the procedure. And next day you prepare for the procedure like that. In residential care, again, BDCs and nitrous both are regulated and restrictive practices, but for dental treatment, there are no restrictions to them. In residential care, you can use both. But again, the decision making should be by after weighing the benefits and the harms and contraindications, advantages, disadvantages, everything applied. And then obtain the consent from the patient and their substitute decision maker. Okay. Cognitive disability is also a contraindication, both actually to your BDCs as well, and even in the nitrous, because in the nitrous you require the patient to respond to your verbal commands. So not all the cognitive disabilities will be contraindicated to nitrous, but if the patient cannot comprehend your commands and you cannot give them the stimulus to see the depth of their sedation, then it might be contraindicated. So it's a relative contraindication there. Patient must understand the verbal commands. Okay. Otherwise, tactile sensation can still work to check the depth of sedation. So that would be it so far. Let's have a recap of whatever we did in the anxiety management. Number one, preference, non-pharmacological strategies. Sedations are of three types: minimal, moderate, deep. In dentistry, you use minimal, not moderate or deep. Minimal has two types: oral BTZs and nitrous. And methoxyfluorine do not have much role in dentistry. Non-pharmacological strategies include your modifying the environment and using calming communication techniques. Various methods like modifying the patient's environment, calming communication methods, regular deep breathing, progressive muscle relaxation, and guided imagery can be used to handle the patients. Then the safety considerations when you are assessing the patient is to check the drug interactions, any airway obstruction, cardiovascular depression risk is there, loss of consciousness also can happen over sedation. So see the patient's assessment with the patient's complete medical history, which is by taking their complete medication history, surgical history, medical history, dental history, any severely limiting heart, cerebrovascular, lung, liver, or kidney disease would be a contraindication. Allergies to such agents or severe anxiety. Reconsider your minimal sedation in such patients. Always seek medical advice wherever in doubt and cannot make a decision. Now, between these two agents, you will always go with a single drug therapy, either oral BTZs or nitrous. You will never mix the two agents. For your inhaled nitrous, advantage is quickly onsets and offsets, easy to give. You can lighten and deepen it, and it will reduce the gag reflex. Disadvantage is the procedure, the equipment cost, and the dependence on the patient for cooperation for the nasal mask. Absolute contraindications would be difficulty to breathe, air trapped in the body like pneumothorax, bowel obstructions, recent middle ear surgeries, recent eye surgeries, and current ongoing bleomycin therapy. For BDCs, advantages can be easily given, well accepted also by the patients. There is no mask, just a pill to pop, and can start anxiolysis before the procedure. Disadvantage includes there are variable adverse effects like memory reducing, impaired memory and cognition, ataxia, delirium, dryness of mouth, blurry vision, and low blood pressure, slow breathing, and paradoxical reactions. Contraindications are completely below the age of 13 and older patients. Cognitive disability, absolute no-no. Absolute no-no with any other sedatives. Not with obese patients. Not with OSA. Not without any carer. Okay? These are your absolute contraindications of B disease and nitrous. you should memorize both of them. That's how you will select your case in exam, which agent you're choosing as per the provided history. And obtaining the consent is extremely important a day before the exam procedure, not on the day. This is an actual exam question. It has to be obtained before the day of the procedure, not on the day of the procedure, so the arrangements can be made. All right, and no problem with the residential care patients also. For dental treatments, both the BTZs as well as nitrous are allowed. And that would be it for today's class. And we will meet for the next TG class day after. And we'll continue with this chapter and furthermore for the next 10 pages.